Good evening, everybody. Welcome to our Zoom tonight as we have special guests on. First, Ileana Bravo, which is our host, which we are so excited to have tonight, as she is a award-winning medical journalist for over 20 years and now works with UHealth on a variety of their programs in English and in Spanish, as well as we have three amazing physicians. But first, I'd like to introduce myself, as I'm Tracy Milgram, the founder of BRCASTRONG. Here at BRCASTRONG, we educate, empower, inspire, and advocate survivors, and thrivers, regardless of predisposition, to help you feel whole again and eliminate the feeling of isolation. Through the journey, we offer pre-mastectomy care packages, as well as bra for brave beauties. And these are programs that offer women products that they need during their procedures, like robes with drain holders, bras, and as well as post-mastectomy pillows to help you heal. And one thing I did not have available 6 years ago when I went under a prophylactic bilateral mastectomy were these items. Families were coming to visit me, friends were coming by. I'm like, what do I wear? What do I have? Don't sit next to me. These are all things that we don't think of on this side. And going through the journey for over 20 years just made me realize this was a niche that I found in the community, and I wanted to open up and have a platform. So for the past 6 years, we are a nonprofit grassroots organization. So I'm going to pass it over to Ileana. Thank you so much for having me.
Oh my goodness, Tracy, thank you so much for putting this on and moving your team of warriors in the community to make this happen. It's a privilege for me to co-host tonight because your personal story has served as an inspiration to make a difference, and it opens minds to this mission, of course. So here we are, some of us donning our pink dresses tonight to kick off our month-long commemoration of breast cancer awareness. You're right, it does go beyond the month of October, but at least our goal right now is to save lives through education and knowledge. I remember, 30 years ago when I started health and medical reporting, that the news on the breast cancer front was not necessarily as rosy, but thank God for all the advances in medical research and treatments and awareness that it has significantly changed outcomes. And today, quite frankly, and these experts who are here with us today can attest to this, an early diagnosis is literally almost a cure at this point. That's how we're looking at it. So that's why I'm about to introduce our UHealth Sylvester Comprehensive Cancer Center physician experts tonight, who are leaders in the industry, and they are going to feature some of the latest and greatest treatments and answer as many questions as all of you have. So I hope that you'll feel comfortable. We have video on for everyone so we can see faces and we can have this wonderful exchange. So I'm going to go ahead and introduce a few of them. We're waiting for Dr. Jessica Crystal, who is our surgeon, and she is still in her scrubs and in the operating room, so she will join us throughout the program, hopefully. But let me kick it off with Dr. Richa Dewar, who is a triple board certified physician in internal medicine, hematology, and oncology, who's a firm believer in compassionate and comprehensive care for her patients. Dr. Dewar specializes in cancers of lung and breast and fondly devotes her time towards strengthening her expertise and acquiring the knowledge and latest treatment modalities, drugs, and research. Dr. Dewar believes her strengths are her clinical acumen from an intense training, broad knowledge, being approachable, which is super important in this area, and an ability to calm people's nerves by just communicating in simple words. Dr. Jamie Spunt is a fellowship-trained breast radiologist who works at University of Miami Miller School of Medicine, Sylvester Cancer Center, and Jackson Memorial Hospital. Dr. Spunt grew up in South Florida, leaving to attend college at Princeton University in New Jersey, and later returning to start medical school at University of Miami Miller School of Medicine. And then Tracy, I'm going to bring it back around to you because I want you all to know that Tracy founded BRCASTRONG in 2015 after fighting alone for over 10 years against her BRCA2 genetic mutation. So Tracy aims to inspire others by sharing her journey, putting her heart out there, and encouraging so many others to do the same. So Tracy, thank you for having me. We're going to wait to make sure Dr. Crystal comes on, but in the meantime, let's open it up with Dr. Dewar and this question. because it is a sequence of events. When you get this new diagnosis of breast cancer, which specialist should a patient see first? Dr. Dewar, take that one, please.
Hi, everyone. This is Dr. Dewar. Thank you so much, Ileana, for the introduction. For everyone, I'm a medical oncologist and I specialize in breast cancer and lung cancer. And I practice medical oncology at 2 locations, at Sylvester, Miami, and Hollywood. So that's a great question, Ileana, great question. And sometimes it's very important for the patients to know, because when patients are diagnosed with breast cancer, first of all, it's a very, very terrifying diagnosis. And when they have this terrifying diagnosis, they don't know who to go. And sometimes they feel that surgery is the way to go. And yes, breast cancer stage 1, 2, and 3, we remove the tumor, but the breast cancer treatment involves chemotherapy, surgery, radiation treatment, maybe anti-hormonal treatment if your tumor is hormone positive. It is very important that you involve your medical oncologist early on. And breast cancer treatment is a multimodality treatment, which means that it involves multiple physicians. It involves a surgeon who will remove your tumor. It involves a medical oncologist who will suggest to you whether you need chemo or not. And it is important to meet the medical oncologist early on before your surgery, because that medical oncologist can advise you if you need chemo before the surgery or not. Not many patients need chemotherapy before the surgery, but there are some factors that we look into, like the size of the tumor, the lymph node status, the type of your tumor, the stage. And if you need chemotherapy before your surgery, first step is to meet with your medical oncologist. That's why it's very important to involve your medical oncologist early on. Also, second reason is because you might be eligible for genetic testing, for BRCA testing. And if you have BRCA testing, then your surgery might be different from just a regular breast cancer surgery. Then you might need both the breast removed. And whether you will be eligible for BRCA testing or genetic testing or not, medical oncologist can make a decision if you are eligible or not. So that's why I think it's very important that whenever you have a breast cancer diagnosis, you approach a cancer center, because at the cancer center, we have the multiple physicians and that can work on your case. Here at University of Miami, we have the breast surgeon, we have the radiation oncologist, we have medical oncologist, we have breast radiologist, who all actually work on your case together. So, and we formulate the plan together. So we work together and make a plan for you, whether you need chemo first, or you need radiation first, or you need surgery first. When do you need chemo, before, after? So that's very important that you see a cancer specialist who can then formulate a plan for you, which is different for every patient. Every patient, you might hear from your neighbor or a friend that I went for surgery first, right? But you need to understand that every woman is different, every breast cancer is different. Breast cancer can be of different stages. Breast cancer can be of different types. And the medical oncologist who specializes in breast cancer can make a plan which is individualized for you, which is personalized for you, and not just a general medical plan. So I think it's very important you see a medical oncologist early on.
Yeah, so Dr. Dewar or Dr. Spoon, whoever would like to also weigh in on this. And by the way, I remind the audience, you see your chat feature right there at the bottom that has like a little bubble and it has a number 2 on it right now. That's what we want you to enter your questions. That way, we could just tee them up for the physicians. But you touched on something important, and that is the genetic testing. So how does genetic testing actually affect your treatment?
Great. Again, a great question. It affects the treatment in many ways. So first, your doctor will make a decision if you qualify for the BRCA testing or not. You must have heard about BRCA testing, which is most commonly associated with breast cancer, which can run in families. But you might not know that there are several other genes, more than BRCA1 and BRCA2, that can be linked to your breast cancer, that can also be linked to cancer syndromes like pancreas cancer, prostate cancer, colon cancer. So when you see a breast medical oncologist, they will take your family history, which means that they will ask you how many members in your family were diagnosed with cancer, what were their ages, what type of cancer runs in your family, and then also like how old are you when you were diagnosed with cancer, what type of cancer you have, because there are certain cancers which are very aggressive. So if you have an aggressive cancer at young age, then you qualify for BRCA testing and genetic testing. If you qualify for that, the medical oncologist will order a test for you. So we check for 83 genes. So not just BRCA1 and BRCA2. It's very important. Not many people know that. So you will get an extended genetic testing panel. And why it affects treatment? Because if you have BRCA mutation, then your risk of breast cancer and ovarian cancer increases than normal population. So if you have that, then your doctor will suggest you to have both the breast removed and also ovaries taken out so that you can reduce the risk of your breast cancer. You must have heard about Angelina Jolie. I think that all started the hype. So she had family history of breast cancer. So she got tested for BRCA, which made her do the procedures of bilateral mastectomy and bilateral ovaries removal. So yes, it affects your treatment in this way. Second, now we are testing, actually, this is very new, hot off the press. There was a big oncology conference in June, ASCO, as you must know, it's a big oncology conference. And we do have multiple clinical trials, practice-changing clinical trials. And in that conference this year, there was a big clinical trial presented, Olympia clinical trial. You can ask your doctor about it. That clinical trial showed that patients who have BRCA mutation can take Parp inhibitor, a drug called olaparib, for 1 year, which reduces your cancer from coming back. It was a practice-changing clinical trial. So which means that if any patient who has BRCA mutation, you will be eligible for that. So now I am testing, and my colleagues here at Sylvester, we are testing all patients because you never know which patient will be positive for BRCA and which patient can benefit from this drug. So it does change your management of receiving this additional drug for 1 year after you have completed your surgery, your chemo, your radiation, to further reduce the risk of cancer coming back. Because when patients come to me and they have finished their treatment, the first thing they ask me, what can I do more? Or what can we do more? Because you want to do everything possible for your patients to make sure they can live longer, to make sure that they can increase their chances of cure, to make sure that they can decrease the chance of cancer coming back. So nowadays we are testing all patients regardless. But yes, if you have family history of, if you don't have, let's say let's say I usually get this question a lot. That's why. So a patient comes to see me and she has cancer, and but the daughter is asking if she should be tested for BRCA or not. Yeah. So first, we should test BRCA testing in a patient who has cancer. If that patient who has cancer has BRCA mutation, only then other family members should be tested. So that's why very important to involve a medical oncologist early on, discuss about whether you need testing or not, and how can you increase your chances of cure.
I want to add a few
Thank you, Dr. Spoons. I was just going to bring you in. Go right ahead.
So I am the breast radiologist, Jamie Spoon. I want to add that when you come in for your mammogram each year, we also ask you questions about family history, personal history, to give you a risk assessment score. Okay, and we stratify patients as high risk, intermediate risk, or average risk. And that will change your screening modalities. Not only that, we do offer genetic testing in the breast radiology clinic to our patients. So patients who have a family history, patients who have a cancer diagnosis under 50 or triple negative cancer diagnosis under 60, various factors are being offered genetic testing with the expanded panel right off the bat at the breast radiologist. Typically, we're the first stop, right? You come in, we do the biopsy, we give the diagnosis. And then at that point, you go on to see your surgeon, your oncologist, the rest of the interdisciplinary team. One other thing about genetic testing is that when you do go for surgery, many patients who do have known genetic mutations may opt for a risk-reducing bilateral mastectomy at the time of a surgery that might have been simply a unilateral lumpectomy, had they not known about a genetic predisposition. So that is a change as well.
Thank you. Thank you for weighing in. And I think that this also adds to what Sylvester Comprehensive Cancer Center is, and that is that it's a multidisciplinary team approach. It's not one, but it's all of these different specialty areas that deal with the diagnosis. Can we talk a little about that?
Yeah, absolutely. We are in constant contact with, the breast radiologist, the medical oncologist, the radiation oncologist, the breast surgeons, discussing patients daily. And then we also have our interdisciplinary conferences several weekly to talk about cases, either that are challenging cases, cases where, the clinician wants to revisit something in the case and talk about it with everyone in one place. And we oftentimes do determine treatment plans at these multidisciplinary conferences. And it's an opportunity for multiple medical oncologists to weigh in on one patient, or multiple surgical oncologists. Someone might say, oh, hey, why don't we consider this drug in this patient, or doing this? And oftentimes patients may really benefit from that, multiple minds approaching their case.
Yeah, Dr. Dewar, I'm assuming that you are going to jump in on that point as well.
Yes, so University of Miami and Sylvester Cancer Center. So it's an NCI designation. It's the only NCI designated cancer center in South Florida. So you can trust Sylvester and all the doctors here at Sylvester. We follow multidisciplinary approach. And what that means, it means that different specialties come together and make a plan for you. It's breast cancer involves, as I said, surgery, chemotherapy, radiation treatment, breast imaging, discussing the case with breast radiologist, if you need more biopsies or not. So we meet every week, once a week, where all the doctors, you have the pathologist who looks at breast cancer under the microscope, the breast radiologist who will read your breast imaging, the mammograms and the MRI, radiation oncologist who would give breast radiation after the surgery, the breast surgeons who would be involved in taking the tumor out, and the medical oncologist who will discuss chemotherapy. So we all come together, we all look at your case together, and then we discuss what would be the best plan for you. And that's why I tell my patients that don't follow your neighbor or a friend or who got what, because that's why it's important to seek a cancer center, because breast cancer treatment nowadays is not the same as what it was 5 years ago. It's a very personalized treatment. It's a very, very individualized treatment. And we make a treatment according to your breast cancer. And when I'm saying your breast cancer, that's very important, that as a patient, when you get a diagnosis of breast cancer and you're going to see your medical oncologist, you need to ask your doctor what stage your breast cancer is at. What is the grade? Patients confuse between grade and stage. So let me take a minute here to explain to you what that means. So grade tells about the aggressiveness of your breast cancer. We can tell about the grade of the breast cancer by looking at the breast cancer cells under the microscope. And it can be grade 1, 2, and 3. If it's a high grade, how aggressive your cancer is. And that can affect what treatment you will get. Then we come to stage. Stages 1, 2, 3, or 4. The stage means if your tumor is limited to breast, or it has spread to lymph nodes, then how many lymph nodes? And if it is outside the breast area. So it's very important when you meet with a doctor to know about the stage of the cancer, the grade. And the number 3, one more important thing that you should ask your medical doctor is about the breast cancer type. So breast cancer type is 3 types. The most common breast cancer is the hormone positive. which means that when we check your breast cancer cells under the microscope, when you go for the biopsy, at that time we check for the receptors. So every cell, the breast cancer, can have 3 receptors: ER, PR, HER2. The most common type is hormone positive, which is very slow growing. If you have hormone positive cancer, you will be eligible for anti-hormonal pill after the surgery. The second type is HER2 positive. HER2 positive means that your breast cancer cell has a HER2, HER2 receptor, and you will be eligible for targeted therapy, which is anti-HER2, which can block that receptor. So it's very important. And the third type is triple negative. If your breast cancer does not have any of these receptors, which is the most aggressive cancer. So these are the things that we take into account. And then we also look at the tumor size, whether the patients have lymph nodes positive or not, the age of the patient, if you have any comorbidities, and then we make a plan together. So it's always not alone. We always work as a team at Sylvester. That's what we mean by multidisciplinary approach.
And that's what makes us unique here at Sylvester. Dr. Jessica Crystal, I believe, has just entered the room. Do we see her on the screen yet?
Oh,
I'm about to introduce.
hi everyone. Y'all, so sorry.
Hi.
Oh my gosh,
Look at
my
her.
hair's a mess. That's embarrassing.
She's in her
Hi.
scrubs. Please don't be.
Beautiful. You're doing such a great job and taking care of patients. This is evening and still you are in the OR. That's amazing.
Thank you.
That's
I just finished. Sorry, I'm sure everyone already told you guys that at Sylvester we try very, very, very hard to preserve all function, preserve lymph nodes when we can. So, but we have to act when there's more cancer. So we just have to make these decisions. So, hi everyone. Sorry.
Well, let me go ahead at least and give everyone the 411 on who Dr. Crystal
Please.
is. Standing there with her scrubs and a mask still dangling. She's a double board certified in general surgery, complex general surgical oncology. She specializes in the surgical and multimodal treatment of patients with benign and malignant breast disease, skin cancer, and other malignancies. Dr. Crystal's research interests focus on the management of breast and skin cancer with the goal of improving outcomes and saving lives. So, I mean, obviously not to get into the details of this case you had, but what requires you to just be there longer and try and save? Talk to us about that.
Sure. So I don't know how much of what has already been discussed, but basically when we see patients with breast cancer, we decide when they need chemotherapy, what kind of chemotherapy they need, and what kind of surgery they need. So if we find a patient with advanced disease like this one, and we treat them with neoadjuvant chemotherapy, and we can shrink their tumor and shrink their lymph nodes, we're able to successfully save the breast and also save them from developing or having a higher risk of developing lymphedema or having increased risk of injury to the major nerves we worry about in the underarm. So for this particular, but the one issue is you have to do it safely and make sure you're clearing all the disease. So intraoperatively, I always have to check whether or not there's any presence of cancer after neoadjuvant chemotherapy or chemotherapy before surgery. Because if cancer has lived and survived beyond the strong chemotherapy, we know that this type of cancer is more aggressive and I have to be more aggressive surgically. So that's exactly what happened. The patient appeared to have a very good response on imaging. Unfortunately, when we checked, she didn't have as good of a response. So we had to proceed with the more complex surgery.
Wow, Dr. Crystal. So literally it is an hour by hour situation. I mean, it's breaking as you're seeing the information come at you.
Sure. So sometimes we do make these decisions like this. Sometimes we do have to have a more lengthy decision-making process because the pathologist can't necessarily check every single cell possible while we're in the operating room. That's one of the things I remind patients. We're only as good as, what I can see with my eyes and feel with my fingers. So I do have to make decisions while I'm here, but I don't have a microscope in the operating room.
Yeah. Is that what makes a place like Sylvester and UHealth special? And the NCI designation, that's all wonderful. It sounds great, but these are the details that make it great, no?
I 100% think so. So part of it is, even though I don't have a microscope here, I have one upstairs. So they are checking for me with me. And then some of this complex decision making, we're definitely pushing the advancing care, taking extra efforts to make sure that we're at the forefront of evidence-based medicine. Simultaneously, all the disciplines will collaborate together and make these decisions together. So it's not just the surgeons deciding, it's the surgeons, it's the medical oncologists, it's the radiation oncologists. We're all doing these game plans ahead of the surgery so that when I come into surgery, I'm ready to go.
Yeah. And your colleague.
Oh, sorry.
Go ahead.
We have those services at Sylvester. One other thing I would like to highlight that we do have at Sylvester is we do have specialized procedures for reconstruction of the lymphatics after axillary lymph node dissection. So unfortunately, if you have advanced lymph node disease in your axilla, one of the risks, as I aforementioned, is swelling of the arm. And we have a specialized department specifically in lymphedema, where some of my plastic surgery colleagues will reconstruct the lymphatic channels to veins so that patients have a significantly decreased risk of lymphedema development.
There are so many questions already coming from our guests. So I'm going to start throwing them out because they're good. Here's the first one. Can a woman with RAD51 go on a PARP inhibitor?
So as of now, the PARP, which is the PARP inhibitor, is only indicated for BRCA mutation, BRCA1 and 2. And also similarly, if you have only BRCA1 or 2 mutation, only then the other surgeries, which is bilateral mastectomy and bilateral oophorectomy, is indicated. Yes, there are other genes which can be linked with your breast cancer, but we don't have any NCCN guidelines to start the patients on PARP inhibitor or any other medications or any additional surgeries. So that's why whenever you have any mutation positive in your test, we recommend that you see a genetic counselor, and which you can only find in cancer center. We have a department of genetics, and they focus on your genes, and they will make a family tree for you depending on how many members in your family has cancer, and then they will provide the best plan for you. But right now we don't have the PARP inhibitor for the other mutations, only for BRCA2.
Can you give us more details as to what the PARP inhibitor, what they are, what it is?
Yes. So before we understand what is a PARP inhibitor, we need to understand what is BRCA mutation. So BRCA, we always talk about BRCA gene. So each one of us has BRCA gene, and BRCA gene is a protective gene. It's protecting us from developing any cancer. So whenever there is a mutation, which means a defect in the gene, whenever you have a defective BRCA, it is defective, so it's not able to do its own function. Similarly, we have the PARP mechanism. So when patients who have BRCA mutation, they don't have a gene which can protect them from cancer, they're at high risk of developing breast cancer, ovarian cancers, and any other cancers. So when we give the PARP inhibitor, which is a targeted drug, which inhibits the pathway, so the cancer cells gets killed and cannot replicate, and that's how it stops the cancer from growing. And it's very targeted. It only works because there's a special BRCA and PARP pathway in the DNA replication and protein synthesis. Very complicated for me to explain, but remember that it's a very targeted drug that is used for BRCA patients who are at risk of developing cancers. And we also use this PARP inhibitor in other kinds of cancers like ovarian cancer and stage 4 breast cancer, but now it is indicated in early stage breast cancer. So even if you are cured and you have BRCA mutation and you want to make sure that this cancer doesn't come back, you can get olaparib, which is PARP inhibitor for 1 year. So that's something new, and you should discuss with your providers.
All right, Dr. Spunt, let me ask you this one. When should we start breast cancer screenings? I know that the guidelines are out there. We should know them by heart, but please tell us.
Oh, it's a controversial and hot topic, right? We as radiologists feel very strongly that breast cancer screening starts for women of average risk at age 40 with yearly mammography. Multiple studies have shown a reduction in breast cancer, or that you catch breast cancer earlier with annual screening beginning at age 40. There are different guidelines out there, but these are the guidelines that we adhere to because of evidence that has shown, again, that you can catch breast cancer earlier and thereby prevent breast cancer related deaths, and also the associated complications that can happen when you don't catch the breast cancer until it's later. So maybe a cancer that might have been caught on a yearly screening starting at age 40 isn't caught until it's already spread into the lymph node, and that increases that patient's surgery or need for chemotherapy, et cetera. So early detection is really key, and we do that with breast cancer screening with mammography beginning at age 40. This is for women of average risk, okay? If you are of high risk, so either you have a known breast cancer associated gene mutation, you have had a biopsy that has shown that you have a high risk lesion in the breast, you have a very strong family history without necessarily a known mutation, you've received radiation to your chest wall for a lymphoma between the ages of 10 and 30, these patients need to come in and start getting screened younger. And typically that is mammography starting at age 30 and MRI starting as young as 25. It depends on the situation, but it is earlier screening for these patients who have a lifetime risk of breast cancer above 20%. For those patients as well, those who are above 40, the recommendation would be for annual mammography as well as annual breast MRI. And a lot of clinicians like for us to alternate that at 6-month intervals so that we're taking a look at the breast every 6 months so that we catch any integrally developing breast cancers.
And here's a question that I think for our moms or our aunties and so forth, is there such a thing as being too old later to have mammograms? Is because supposedly there's no estrogen driving it, no progesterone, no hormones. 75 or what do you say?
Yeah, so those guidelines are a little bit murky as well. We say something that's a little bit vague. It's between 5 to 7 years of life expectancy. Do we really know our life expectancy? And so, yeah, it is true that cancers in the elderly are typically more slow growing, more indolent, but we screen patients who want to be screened. We have 90-plus-year-old patients in our clinic who are coming in for screening. And by the way, we also diagnose in that patient population and treat. And so, the textbook answer is to within 5 to 7 years of life. I would say if you have another, severe illness and you're 87 years old and you have a metastatic unrelated cancer, it's unlikely that you need to keep coming for annual mammography. That's not going to contribute to your life expectancy. But there are other patients who are very healthy at 92 who are coming in.
Yeah,
I agree. I would like to add that, age is just a number. And there are some patients who are 75, but they're so healthy and healthier than my 50-year-old. And they would live beyond like 90 and 100. And if they have 25 years of healthy living, and if we can detect breast cancer, which can also happen in older population, then why not? If you can detect something and can cure a woman with cancer. So I tell my patients that I don't look at the age, I look at you. And if you are healthy and if you're living, then you should not stop getting your mammograms.
and how about after a mastectomy? Now, here's something that's on our mind. Are you supposed to continue having screenings?
No, not if you've had mastectomy and there hasn't been significant tissue left. We do have some patients that have gone for mastectomy. Maybe they had mastectomy 20 years ago and there's significant breast tissue that is left in those patients. It's rare, it's very rare, but we will screen. But no, after mastectomy, mammography is not it's really not feasible, and nor is there a lot of added value. Of course, if you have pain, if you have an area that you're feeling that's concerning you, if you have a symptom, that's a different story, right? But this is just talking about screening, and we do not screen patients post mastectomy.
I just want to
So-
comment on the mastectomy part, just to add to it. So that's one of the reasons why I do think Sylvester is special, is they only have hired board certified surgeons specifically in either breast surgery or surgical oncology to manage your breast cancers. So we have been specifically trained to create the appropriate level of flaps where we remove as much breast tissue as physically possible while maintaining the aesthetic appearance of it. That definitely in South Florida is not the standard everywhere, but at Sylvester, people like myself, we seek out jobs here because it's an NCI designated center. So it goes hand in hand. Simultaneously, exactly what Dr. Spoot said, if you have symptoms, most of the time with the mastectomy flaps that we create, we're able to feel anything, but sometimes even before we go for detection on imaging.
Mhm.
Yes, so even after patients, they get mastectomy, it's although you cannot get breast imaging, but it is very important to see the doctor and self-examine your breast and see your oncologist or surgeon every 6 months who can check your chest to see if they have anything new findings. So yes, even though you don't get breast imaging, but don't forget to examine yourself breast, or see the doctor who can examine your breast for you.
And going back to the multidisciplinary approach, there have been times that I'm in clinic and the oncologist or the surgeon is running his or her clinic, and they'll call and say, hey, I have this patient, she's post-mastectomy, but I think I feel something. Could you squeeze her in so that we can take a look? And we do. And oftentimes it's, benign post-surgical change. That's what we hope for. But we are available to communicate on that right on the spot.
All right, here's another question. And again, genes are on our mind tonight. If you've been diagnosed with the BRCA gene, how old should your daughter be when she has her first mammogram? This lady says, I have a 17-year-old, but got ovarian the first time at 19, and I'm BRCA1. Very specific.
Okay, so in this case, I would say that she should start with breast MRI so the daughter hasn't been tested, mother is BRCA1, how old should she be when she has her first mammo? Based on this information, I would say she would start with mammo at 30, potentially with breast MRI at 25. Typically, we can also say, 10 years younger than the first relative, than the first degree relative who was diagnosed, but not 25.
Okay.
Well.
Now here's one that's also important. What are some of the key questions we should be asking our surgeons to determine the best reconstruction options?
Sure, so obviously everyone's different. A lot has to do with one, whether or not you have a genetic mutation. So that will help determine, what we need to do. Two, if you truly have cancer. So there's some people with a genetic mutation with no cancer, some people that do have cancer. The second thing I look for is the amount of disease present. And that's probably one of the key things we have to figure out. While my attention is keenly on the aesthetics, and I work very closely with a lot of plastic surgeons here for that reason, my main number one goal is ridding you of cancer. And that's one thing that I always tell my patients. I am going to put my cancer cap on and kill all your cancer. However it looks after, I do my very, very best to make it as beautiful as possible. However, cancer comes first. So your extent of disease is super important. If you have lesser extent of disease and you choose a mastectomy, then we could potentially go straight to implant or perhaps an intermediate step of expander. However, if you have a lot of disease and we're anticipating radiation, there's times that we actually will delay that because unfortunately, everything has risks and benefits, and there are risks to plastic surgery. So one of my concerns is if a patient has a lot of disease, they get some kind of plastic surgery and they unfortunately have a complication that will delay future chemotherapy, that might delay the radiation. This is cutting years off their life. I don't think that anyone would outweigh, the appearance of their breast to years of their life. And this is typically some of the general principles of how I guide patients. The other thing to think about is whether or not they're getting that axillary lymph node dissection, because a lot of the plastic surgeons are the ones that are doing that fancy lymphatic procedure I'm doing.
Mm.
So if they have advanced disease there, I'll also pair them up with a specialized plastic surgeon who has the skills to do this microscopic surgery, and we'll do that at the same time as well.
And therein lies the rub. Not all plastic surgeons are the same. How do we know which ones are qualified for breast cancer reconstruction?
So it can be a mixed bag. I would say one of the key things that I look for is board certification. Board certification means that you've successfully finished residency, you've successfully finished fellowship, and you've sat in front of some of the leaders in the entire world in plastic surgery and defended your decisions and proven. The plastic surgery boards is actually very difficult. You don't just defend your decisions, but they also look at your cosmetic outcomes. So if you have passed this board exam, likely you have the skills to do what it takes to get reconstruction. Additionally, though, I would ask the plastic surgeon how many of these they do in a year. So if it was somebody that does a little bit of breast, a little bit of this, a little bit of that, I may not choose them as much as somebody who's doing probably upwards of 5 to 10 breasts a week. Certainly you will find one of those at Sylvester, 100%.
Very good. Somehow I knew you were going to have a definitive opinion on this one. Here's an audience member who asked, I was only supposed to get surgery and radiation, but after the Oncotype of 32, I needed chemotherapy also. Today I had Mohs surgery for skin cancer. Has my chemo and radiation increased my skin cancer chances?
So chemotherapy and radiation do not increase your risk of skin cancer. There are certain other things which can increase your risk of skin cancer, like sun exposure and predisposition to skin cancer, but chemotherapy and radiation does not. And then you mentioned Oncotype. So for other people, what is Oncotype? So Oncotype is something that we check in hormone positive. If your cancer is hormone positive, then not every patient gets chemotherapy. With the help of Oncotype score, which is done after the surgery, we can make a determination if your cancer would benefit from chemo or not. So that's, again, one more important thing to discuss with your medical oncologist to see if you need chemotherapy or not. 5 years ago, we were treating all patients with hormone positive with chemotherapy. And then we saw that there are some patients who, regardless of chemo, would live longer and they would have 5-year survival, 95%, whether you get chemo or not. So why to expose those patients with harmful effects of chemo? So at Sylvester, we weigh the risk and the benefits, and we only give chemotherapy to patients who actually need it. That's where Oncotype comes into play, but chemo and radiation do not cause skin cancer.
Okay. Let's discuss the elephant in the room, and that is the whole COVID mess and how this has affected patients wanting to safely come in to be checked. Checking your breast in telemedicine virtual visit is not something that's possible, but certainly virtual visits, I know, are helpful for second opinions and so forth, and to at least continue the treatment. How can you reassure patients out there that Sylvester is safe and a place where they can come in and be treated?
So at Sylvester, we take all the precautions to protect you against COVID, and few of the things that we take extra care in, that we have social distancing even in the waiting room. We have check-in process where you can stay in your car and you can check in online. You don't have to come and wait in the waiting room. You will be informed. They will call you and message you whenever your doctor is ready. So you just stay in your parking in your car, and then when your doctor is ready for you, if you don't want to wait in the waiting room, you just come and directly a doctor sees you. After every patient, we clean the room with sanitizing wipes. The doctors are hand washing multiple times in between patients. We are using barriers like N95 mask, the face shield, the eye protection for you. And we also have a screening procedure that any patient who has any symptoms suspicious of COVID, they're not allowed to enter the building. Also, patients are not allowed to bring visitors. I know this is Sometimes patients are not happy, but this is for your protection, that we want to make sure that you are safe, and we don't want to have any more visitors inside the building. But whenever we see a cancer patient, which is, again, cancer is a frightening diagnosis, as a medical oncologist, I always call patient's family member or your friend over FaceTime so they can be part of the visit. So we are taking all the precautions. And yes, COVID-19 has changed the oncology care because now we have virtual visits, which has their pros and cons, right? You cannot self-examine, you cannot breast examine in the visit. You cannot measure the size of the tumor. You cannot see if the tumor is shrinking or not, but it gives an opportunity for the patients to do a visit from your home. You can be safe there, and we see the patients. So if you're getting chemotherapy, your medical oncologist would like to see you before every visit, because it's very important to make sure that you are strong enough to get the chemo treatment. Virtual visits have changed the oncology care in a way that you can sit in a different country. You can be in a different country and you can seek a second opinion. If you want to seek a second opinion, if you want to know, if you want to have a consultation with the doctors at Sylvester Cancer Center, you send me an email and I can arrange you for that. And we review all the medical records online. We discuss your case with you. And then if you would like to get treatment, only then we bring you in at Sylvester. So it has completely changed the oncology care. But I think it gives an opportunity for the patients to sit at home, at least discuss with your oncology team over the Zoom meeting. We also do multidisciplinary meeting. So for breast cancer and lung cancer, when we see any patients for second opinion, you will be seen together on Zoom by a radiation oncologist, breast surgeon, and a medical oncologist together looking at your case. So that's also very important in the part of telemedicine.
We're running out of time, which is incredible. We've had such a great discussion. We still have a few more minutes left, but a couple of points that I think are important to talk about for our entire panel to address. And that is, the secondary effects of the treatment for cancer are pretty severe, are pretty intense, both mentally and physically. It's like we're curing the cancer, but we're also making you sick in many other ways to make you better. If we could address that point, and then the final point is how you all work together with BRCASTRONG, with Tracy's wonderful group. So go ahead and begin. Perhaps Dr. Spoon wants to begin.
As to the mental and physical impact through breast cancer treatment.
Yes.
Yeah, I think that oftentimes, as the radiologist, we give the initial diagnosis, and there's this shock, and it's very difficult to know what to expect. And then you get sort of hooked into your surgeon and your breast oncologist and your radiation oncologist. And then all of a sudden you're living a totally different life with cancer treatment. And, I think that breast cancer treatment is so individualized. It really depends on if you are getting chemotherapy, what your surgery is, and maybe my colleagues can speak to those details. But there is, obviously a psychological and physical toll of going through that treatment in order to heal you from the breast cancer that you're dealing with.
Yeah, and I'll remind, of course, your colleagues that Sylvester has incredible support groups specifically for this. So take it away.
Yes.
So one of the things I'd like to comment is one of the things that Sylvester does have is a mentorship program for patients who have survived and gone through different types of treatments. And so then they're available to talk to you, if you like, about the different approaches. So a lot of times the question that gets asked of me the most, Doc, should I just get my mass removed or should I have the whole breast removed? And I try to guide patients exactly like they're my family members, 100%, but in the same respect, it's not me. And I always tell them, some patients just like their breast the way it is, and they're okay with removing a little bit. Other patients can't think of the thought of one more mammogram because this was so traumatic, and they just want it off, and they'll accept the feeling of an implant or the other reconstructive technique that I failed to mention before, which is the movement of another part of your body, for instance, the lower belly fat or some of the muscle, up to reconstruct the breast. Regardless, I do these cases, I see what the outcomes are, but I haven't been in your shoes. So I can only guide you as much as I can. And so when the patient's open to it, I'm happy to connect them.
And Dr. Dewar, maybe you want to sort of close us out a little bit on how you all work together with BRCASTRONG and how that partnership is valuable and powerful.
So, as a woman, so breast cancer is common in women, and also we see breast cancer in male patients also, but as a woman, you are the one who is the backbone of the family. So when something happens to you, it's very important that you seek the help of the other women in your neighborhood, in your circle, in your society to seek help, because I tell my patients that don't go through this alone. You need help. And we can build help for you. We can seek help in breast cancer support societies and BRCASTRONG, and that's how Tracy can discuss more, because they are similar patients, similar women who have gone through the same pain, the same diagnosis, the chemotherapy, and they can better guide you. And we need support for those patients, because it's not just the physical aspect of breast cancer. It's not just the chemotherapy side effects. It takes a mental toll on you. Every time you go for your mammogram, it increases your anxiety levels. Going through the chemo treatment, staying in the bed, not being able to taking care of your family, not being able to work can actually cause a lot of psychological issues, anxiety, depression. And that where we can provide, as Ileana and other people mentioned about the support services that we provide at Sylvester. We have psychological services, we have music therapy, we have meditation, we have yoga to distract you. And then we have great support, BRCASTRONG Society, who can help you guide through this process.
Yeah, very well said. And I know, Tracy, this is so near and dear to your heart, which is why you go out of your way to do events like this, virtually or in person, because you're so active. So just talk about that tonight and take our take-home message for this evening's powerful program.
So much, especially to the physicians who joined us and took the time. Obviously, it's true dedication that you guys have to making a difference. The reason for my platform is to educate, because I did feel alone. I didn't have garments. I didn't have anything available. And I don't think that anybody should go through this alone. And, being that I took preventative action, we have board members that have had breast cancer or had ovarian cancer, because I feel that when I walk out of a doctor's office, I don't want to feel alone. Going into these appointments, going into treatment, like I get text messages from women who are just leaving radiation, who are just leaving chemotherapy. Those are the connections that you need to make. It's not just like physically heal, right? It's the mental aspect. Dr. Crystal touched on a lot of different things, going through and changing your breast, the new normal, right? Even for somebody who took preventative action and faced complications, it's accepting who you are. And that's what I want to do at BRCASTRONG, and will continue to do, is support and educate and really provide information to women. And again, it's just not education. It's, coming home from the hospital. What do you hang out in your house? What do you have? For the women that have lymphedema, right, Dr. Crystal, that cannot afford lymphedema sleeves. So here we are letting these women suffer in pain and not having a program for them. No, we at BRCASTRONG created that program. We are starting an ovarian cancer program in January. We are super excited. The more information and the more support we can have from our community will continue to allow us to make a difference. So I'm honored to have you guys as part of our program, as one of our sponsors. We just want to continue to make sure that we keep up the same work and continue fighting, because breast cancer, as we know, and ovarian cancer is not just September and October. So let's make sure we continue to educate and share these valuable resources and talk more about different reconstruction options, have somebody specialize this. As we all know, Sylvester's a multidisciplinary center, which is a huge advantage to us, being able to have a radiologist on, a breast surgeon, a plastic surgeon, an oncologist, just coming together and really supportive. It's just an amazing experience. So we are so honored to work with you guys. And Ileana, it's always a pleasure to have you on as a host to talk to you. And, if you're not following BRCASTRONG on Instagram, make sure you stay up to date. We're always continuously doing education, as well as we will have this up on YouTube, and we'll do some clips on Instagram to share to make sure that everybody's aware of knowing your options. Again, knowledge is power. Be your own advocate. That's what we are here to implement in our community.
And Tracy, let's remind everyone that Sylvester is growing in leaps and bounds. They already have 9 locations across South Florida. Let's put up some contact info on the screen so people know how to reach out, how to find, how to call, how to, email. 5 of the locations are, let's see what we have. We have in Broward, Fort Lauderdale, Hollywood, Plantation, Coral Springs, Deerfield Beach. There are all your numbers on the screen. The newest facility in Aventura, plus, of course, our main campus in the Civic Center, Sylvester at Lennar and Coral Gables, and even our Kendall office. So there you have all the numbers for you to outreach. We'll leave them up longer. And I'm sure that Tracy, with her great work, will put all this up on social media as well. But can I thank you from the bottom of my heart? Our physicians tonight were fantastic. Dr. Crystal, thank you for jumping out of the OR. Dr. Spoon, Dr. Dewar, you are great communicators. You are women of power tonight, female oncologists, showing what this is all about and how women should take charge and control of their own bodies and their minds and do what's right. So thank you all tonight for joining us. Good night, everyone. Stay well and stay safe out there.
Thank you.
Thank you. Bye.